गुड मॉर्निंग एवरीवन। वेलकम ऑल। पिछले लेक्चर्स में हमने ईसीजी के बारे में स्टार्ट किया था। आज के लेक्चर में हम आगे का पार्ट कंटिन्यू करेंगे। तो बिना टाइम वेस्ट किए हुए आई वुड रिक्वेस्ट डॉक्टर पूजा टू प्लीज कंटिन्यू विद द फर्दर लेक्चर। पूजा यू कैन स्टार्ट। हेलो। हेलो।
Hello.
हेलो।
Hello.
पूजा यू कैन स्टार्ट।
But I cannot hear you. Hello.
हेलो। हेलो।
Hello. Am I audible?
यस।
Okay. Thank you, Dr. Subodhpal. Good morning, everyone. Myself, Dr. DrPoojaPrabhu, MD Scholar from Kai Chikitsa Department. And here is an initiative undertaken by my team to conduct lectures on ECG to make it easy and effortless to interpret. Before starting with today's lecture, let's have a quick recap on what did we learn in last lecture. Now, I would like you all to memorize the first picture of a normal ECG lead, which has been presented on your screen. Nextly, there are 3 bipolar leads, 3 unipolar leads, and 6 precordial leads. Now, coming to the Einthoven's triangle, lead 1 will record the voltage from right arm to left arm. Lead 2 will record the potential difference from right arm to left leg, and lead 3 will record the potential difference from left arm to left leg. Impulse is generated from SA node. That is why it is called as the pacemaker of the heart. There are 3 events that take place in a cardiac cycle. This is important because these events will interpret the deflections on the ECG. The first event is atrial systole or contraction, which is of 0.1 second. Ventricular systole and contraction is the second event, which is of 0.3 seconds. And ventricular diastole or relaxation is of 0.4 seconds, which is the third event that takes place in the conduction system of the heart. This entire is called as cardiac cycle, which is of 0.8 seconds. Now, this is what we learned in the last lecture, that initially all the cardiac cells are at rest, so they are negatively charged. So whenever the current is traveling from a negative electrode to positive electrode, it will show a positive deflection, that is the upward deflection on ECG. Whenever the current is traveling from positive electrode to negative electrode, it will show a downward will show a upward deflection on the ECG. And whenever there is activity, what does P wave represent? It represents atrial depolarization. QRS complex. QRS complex represents ventricular depolarization, and T wave represents ventricular repolarization. I hope it is clear until now. Now, the today's lecture is everything about augmented leads. Okay. What are augmented leads? Augmented leads are nothing but unipolar leads. So which means they always have a single positive electrode referred against the combination of other limb leads. Augmented leads, what do? They record the flow of current from heart to right atrium. This will be recorded by the electrode AVR. Now, also the current flowing from heart to the left arm will be recorded by AVL, and the current flowing from heart to the left leg will be recorded by AVF. For this purpose, we use a hexa-axial reference system in order to determine the axis of the heart on the ECG. This is always done in a frontal plane. I'll be showing the image in the next slide. Augmented leads are used to determine the axis of the heart. There is one normal axis, one left axis deviation, one right axis deviation, and one is the extensive axis deviation. Trick, when you have a ECG, sometimes it would be a flat line, or sometimes there would be slight deviation. Once you locate that, for example, if AVL is the most isoelectric line, then what you have to do is check for the perpendicular line, that is the lead which is in 90 degrees with AVL. You have to check that. Okay, see here. If AVL is supposed to be the most isoelectric line, this is nothing but the picturization of hexaaxial system. If AVL is the most isoelectric line, then the line perpendicular to it will be lead 2. Okay. So what is the axis of AVL? It is, for example, minus 30 degrees. And the axis of lead 2 is plus 60 degrees. So this axis of heart here, okay, this axis of heart here will lie between minus 30 degrees to plus 60 degrees. Okay. So is it normal or abnormal? I'll tell you how does this work. Coming to this part is, remember that how are the leads placed in the Einthoven's triangle? That is lead 1, lead 2 and lead 3. Similarly, these augmented leads are also placed in the same manner. Okay. Now, AVR. AVR, if we consider that AVR has the positive electrode, then what will be the negative electrode? The negative electrode will be the average potential difference between the electrode placed on the left arm and left leg. I hope you are able to see the diagram. See, now AVR is positive electrode, okay, and the negative electrode will be the potential difference connected between left arm and left leg. Similarly, if AVL has the positive electrode, then the negative electrode will be the mean potential difference between right arm and left leg. Okay. And if AVF has the positive electrode, then the negative electrode will be the potential difference, that is the mean potential difference between right arm and left arm. I hope it is clear in the diagram, okay? Now, what is normal axis? Normal axis is between, just keep looking at the diagram, okay? Normal axis is between minus 30 degrees to plus 90 degrees. Now, this happens always in the clockwise direction, huh? Left axis deviation is between minus 30 degrees to minus 90 degrees. Right axis deviation is between plus 90 degrees to plus 180 degrees. And extreme axis deviation is between minus 90 degrees to minus 180 degrees. What is the trick that I have told you all is always locate the isoelectric line in the ECG. If we consider, or for example, let's take AVL is the most isoelectric line in the ECG that we have right now. So if AVL is minus 30 degrees, we have to locate the perpendicular line, perpendicular axis to the AVL. It is nothing but lead 2. So the axis of this heart will be from minus 30 degrees to plus 60 degrees. If we correlate whatever I have mentioned in the besides the diagram, so this will represent the normal axis. Now, what if I say that AVL is the most isoelectric line, but the line now what if I say if let's consider AVR to be the most isoelectric line. Okay, so what is the axis of AVR? It is plus 30 degrees and the line perpendicular to it. So let's see what is the line perpendicular to it. It is lead 3, which is plus 120 degrees. So what will be the axis of this heart? Anyone could uh, answer? Or even if this is not possible, I'll tell you the most easiest trick which you can actually use while interpreting ECG. If it's possible for everyone to answer. Okay, no issue. I'll tell you how to relocate it. Okay, I just hope you can take the snapshot of this, that how we are supposed to determine if it is left axis deviation or right axis deviation, or if the ECG given to you has a normal axis. Now, coming to the contiguity of leads, what do you mean by contiguity? Contiguity is nothing but when two or more leads
Pooja,
look
please
at the
rotate your
adjoining.
mobile, please.
Okay, okay. But I'm not able to rotate it. Just a second. Is it readable now?
Yes, now clear.
Okay. Okay. Coming to the contiguity of lids now, what do you mean by contiguity? When two or more lids are looking at the adjoining tissue of the heart. So if we consider the diagram here and the interpretations which I have mentioned on the left hand side, if inferior surface of the heart is to be visualized, now you can see that here lead 2, lead 3 and AVF are observing the inferior surface of the heart. That is the surface which is above the diaphragm. Okay. For the lateral surface of the heart, the leads 1, AVL, V5 and V6. For septal surface of the heart, leads V1 and V2. For anterior surface of the heart, this is nothing but how the ECG leads are observing the heart. Okay. Now, for anterior surface of the heart, it is V3 and V4. When more than 3 leads are involved, for whenever there is a defect in the ECG and when more than 3 leads are involved, we call it to be an extensive MI. What is myocardial infarction? We'll be seeing in the further lecture, but just keep this in mind. Okay. Now, this is the hexaaxial system. This is what I was mentioning. If AVR is supposed to be the positive electrode, then the direction of the mean average potential. Okay. Look at the direction. So what do we say? Whenever the cardiac cells are rest, they are negatively charged. So AVR will be placed exactly on the same side where lead 1 is placed. So when AVR, the cells of the right side are negatively charged. And look, the negatively charged cell will be moving in the negative direction. So whenever the current is moving from negative to negative, it will show a sorry. Whenever the current is moving from positive electrode to the negative electrode, it will show a downward deflection. That is why all the waves in AVR are negative. This is the only trick which we use in the ECG lead to determine if the leads are properly arranged or not, because in all the leads only AVR and lead V1 are always negative. Sometimes even V1 has a positive deflection, but AVR will always be negative. If AVR is positive, then it is an abnormality. Firstly, you have to check if leads are properly placed or not, and secondly, you have to check if the patient has any symptoms. Now, what does AVR represent? It represents right ventricle. So you have to check if the patient has any abnormality corresponding to right ventricle. Also, it represents interventricular septum. The trick here is AVR will always be negative. Okay. Now, sorry. Coming to the AVL part, if we consider the AVL to be the positive, now look at the average potential difference between right arm and left leg. So here the waves will be the impulse will be traveling from negative electrode towards the positive electrode, right? So whenever the current is traveling from negative electrode towards the positive electrode, the deflection will always be positive. That is why the leads of the AVL will always have a upward deflection. Now, what does AVL represents? It represents lateral wall of left ventricle. Okay. Now coming to AVF. If AVF is positively charged electrode, then the negative part will be the potential difference or the mean potential difference between right arm and left arm. So the current here will be traveling from from upward to from negatively charged electrode towards the positively charged electrode. That is why AVF will always be positive in the ECG. AVF represents inferior aspect of the heart. Okay. Just keep in mind what does these leads respectively represents. Now coming to the precordial leads. Precordial leads are V1 to V6. All the precordial leads are always positively charged because they are unipolar leads. Now, what we have to think here is there are two concepts. When we travel from V1 to V6, there is R wave progression, and whenever we travel from V1 to V6, there is S wave regression. That is the height of the R wave will keep on increasing, and the height of the S wave will keep on decreasing. Why this happens? Because the thickness of the left ventricle is greater than the right ventricle. So whenever the current is passing from atrium to the to the ventricles, and whenever the ventricles are contracting, the left ventricle will contract more powerfully as compared to the right ventricle. So V1 and V2 represents right ventricle, as in the maximum part of right ventricle. Okay. And what does QRS complex represents? It represents ventricular depolarization, that is ventricular contraction. That is why whenever we travel from V1 to V6, see, I have mentioned in the diagrams that is there is slow R wave progression, and whenever we travel from V1 to V6, there is slow S wave regression. Okay, I hope this is clear. Look at the axis. How is V1 to V6 placed on the heart? They all are positively charged because they all have a single electrode. Now, coming to this part is why is the axis important? Right axis deviation and left axis deviation. You were not able to judge it through that hexaaxial system, right? So keep these two rules in mind. Whenever lead 1 is negative, that is whenever lead 1 will show a negative axis or negative deflection, and lead AVF is positive. Whenever lead AVF will show a positive deflection, it is right axis deviation. And whenever lead 1 will show a negative, whenever lead 1 will show a positive axis and AVF will show a negative deflection, that is the ulta of RAD. Okay, in RAD it is lead 1 showing negative deflection and AVF showing positive deflection, and in LAD it is lead 1 showing positive deflection and AVF showing the negative deflection. Whenever lead 1 is positive and AVF is negative, it is left axis deviation. Now, sometimes it is not possible to figure out certain abnormalities when comparing to the bipolar leads and the precordial leads. That is when these augmented leads plays the vital role. Now, what does right axis deviation indicates? It indicates pulmonary hypertension or right bundle branch block or right ventricular hypertrophy or right anterior fascicular block. What are all these pathologies? I'll be explaining in further lectures. Just remember what does right axis deviation indicates. Now, what does left axis deviation indicates? It indicates left bundle branch block, left ventricular hypertrophy, inferior wall MI, left anterior fascicular block, and there is one more syndrome called as Wolff-Parkinson-White syndrome. Hope the lecture is not fast, okay?
No.
No, okay. So what are the golden points we need to remember up till now is we have seen the axis and whatever the leads are representing on the ECG. Okay. So summarizing up till now is lead 1, AVL, V5 and V6 will represent the lateral wall of the heart. Lead 2, Lead 3 and AVF will represent the inferior wall of the heart. V1 and V2 will represent septal wall of heart. Lead 1, AVL, V1, V2, V3, V4 will represent anteroseptal wall of heart, and AVR actually represents right ventricle, but there is something that AVR also represents that I'll be informing you all in the next lectures when we'll be studying myocardial infarct. Okay, now these are some basic points of an ECG. Paper speed, whenever you put the lids, there is a sequence. This is a trick that the RBGY. So the red will be placed on the right arm. The black, which is nothing but the neutral, the black color lid will be placed on your right leg. The yellow color lid or the electrode will be placed on your left arm, and the green color lid that will be placed on your left leg. So the sequence will be RBGY from upwards, downwards, downwards, and upwards. This is your sequence. Okay. So what will be your paper speed when you mention, see, if you have seen the ECG machine, there are three speeds: 10 millimeters, 25 millimeters, and 50 millimeters. Normally we set the paper speed on 25 millimeter per seconds. If you see this box, okay, just wait. Okay, if you see this box, okay, there is a small box which I have drawn here. In the small boxes, in the big box there are 25 squares. Okay, so the each large box here represents 5 millimeter, which is nothing but 0.2 seconds. If you take a scale ECG and if you put it on a ECG graph paper, the big box represents 5 millimeter, which is nothing but 0.2 seconds, and the small box represents 1 millimeter, which is nothing but 0.0. If you multiply it by 5, you will get the answer 0.2 seconds. Okay. Always remember, in an ECG, whenever there is any wave, if you consider P wave, if you consider QRS complex, if you consider T wave, the width is always important. The length is also important, but the width of any wave is always important. Okay. So PR interval should always be less than 0.02 seconds. That is QRS complex should always be less than 0.12 seconds, or that is less than 3 little boxes. These are the two things you need to remember. QT interval is always very difficult to calculate because QT interval is the largest interval. Sometimes in an ECG, you may have a prolonged QT interval. This is very rarely seen, majorly seen in cases of poisoning. Now, to calculate the heart rate, we always look at lead 2. Lead 2 is more specific to heart rate. Now, what if you have to do is, the easiest trick is you have to take 300 as the numerator and divide it by the number of large boxes between two RR interval. Okay, this can only be done if you have a sinus rhythm. If it is not possible to calculate with the help of 300 divided by number of large boxes, then you will take 1500 in the numerator and divide it by number of small boxes between the RR interval. How is this done? I'll be explaining you in the next lecture, because next lecture is a bit tricky and I hope maximum number of students will be joining it, because we'll be studying myocardial infarct in the next lecture. Until now, I hope the axis and the deviation with respect to the electrode and what it represents on the ECG is clear. If you have any doubts, this section is a bit small because whatever was pertaining to the leads, I have covered it up till now. The next sessions will be a bit big, and what about you have to pay quite attention in the next sections. So if you have any doubt in these sessions, I'd like to entertain. I know the axis part is a bit difficult, but the rule which I have set, that lead 1 will be negative and AVF will be positive. In any ECG, you have to go for right axis deviation. And if lead 1 is positive and AVF is negative in any ECG, you have to go for left axis deviation. Any questions? I hope the contiguity part is also clear, that which leads represents which part of the heart, like this one. This is the slide. Actually, you can take some snapshot. If you guys have any doubt, you can actually ask in the messages form also, or if you can unmute yourself and ask, I am ready to entertain.
I think we can conclude. If anyone has any doubt or question, you can ask in the group also. Okay. Thank you, Pooja ma'am, for the beautiful lecture, making it easy. Thank you.